Emma Richardson was living her dream. At 28, she'd just been promoted to senior graphic designer at a prestigious advertising agency in Chicago. Her days were filled with creative projects, client meetings, and the satisfying glow of her dual monitor setup. Another late night, her boyfriend Marcus asked, bringing her coffee at 11 p.m. as she finalized a campaign pitch. "This is the big one," Emma smiled, her fingers dancing across the keyboard. "If we land this account, I'm looking at creative director by next year." She was healthy, active, went to yoga twice a week, and had no family history of serious illness. Life was exactly where she wanted it to be. But 3 months later, everything changed. It started with headaches. Not unusual for someone staring at screens 12 hours a day, Emma reasoned. She bought blue light glasses, adjusted her monitor height, took regular breaks. The headaches persisted. They were different from her occasional tension headaches. These were intense, pounding sensations behind her eyes, worst in the mornings. They'd wake her at 5 a.m., throbbing with each heartbeat. "It's like someone's inflating a balloon inside my skull," she told Marcus one morning, pressing her palms against her temples. She started taking ibuprofen daily. Sometimes it helped, mostly it didn't. Then came the visual disturbances. During a client presentation, Emma's vision suddenly blurred. The PowerPoint slides swam before her eyes, colors bleeding together. She blinked hard, and it cleared after 30 seconds. "Just tired," she told herself, "need to sleep more." But it happened again and again. Brief episodes where her vision would gray out, sometimes accompanied by seeing double or strange flickering lights at the periphery of her vision. "You should see a doctor," Marcus urged after she nearly walked into a door, her vision blanking momentarily. "I will," Emma promised, "after this campaign launches." The campaign launch was a success. Emma celebrated with her team, glasses of champagne raised, congratulations flowing. She ignored the persistent headache pounding behind her eyes. That night, she woke at 3 a.m. to excruciating pain. The headache was so severe she couldn't move without waves of nausea crashing over her. When she opened her eyes, her vision was severely blurred, as if looking through frosted glass. "Marcus," she called out, her voice panicked, "something's really wrong." He rushed her to the emergency room. "When did the headache start?" the ER physician, Dr. Sarah Chen, asked, shining a penlight in Emma's eyes. "3 months ago, but they've gotten much worse." Dr. Chen's expression grew serious as she performed the ophthalmoscopic examination, looking into Emma's eyes with a specialized instrument. "I'm seeing papilledema," Dr. Chen announced to the resident beside her. "Bilateral optic disc swelling. We need an urgent MRI and MRV to rule out mass lesion or venous sinus thrombosis." Emma's heart raced. What does that mean? "Your optic nerves are swollen, which suggests increased pressure inside your skull. We need to find out why, immediately." The MRI took 45 minutes. Emma lay perfectly still in the claustrophobic tube, the machine's rhythmic banging matching her racing heartbeat. Each throb sent pain shooting through her head. Dr. Chen returned with a neurologist, Dr. James Patterson, a specialist in neuroophthalmology. "The good news," Dr. Patterson began, "is that we found no tumor, no blood clot, no structural abnormality in your brain. The MRI is essentially normal, except for some subtle findings." Emma exhaled. "So what's causing this?" "The bad news is you have something called idiopathic intracranial hypertension, or IIH. It used to be called pseudotumor cerebri because it mimics the symptoms of a brain tumor, but there's no tumor present." Dr. Patterson pulled up a diagram on his tablet. "Your brain and spinal cord are surrounded by cerebrospinal fluid, or CSF. This fluid is continuously produced and reabsorbed, maintaining a stable pressure, usually between 10 and 20 centimeters of water." He pointed to the diagram. "In IIH, something disrupts this balance. Your body either produces too much CSF or doesn't reabsorb it properly. The pressure inside your skull rises, sometimes to 40 or 50 centimeters of water, or higher." "Why is that dangerous?" Emma asked. "Because your brain is encased in rigid bone. When pressure increases, it has nowhere to expand. The elevated pressure compresses your optic nerves where they enter your skull, causing the swelling we saw on examination. Left untreated, this can cause permanent vision loss and even blindness. Blindness? We need to act quickly, Dr. Patterson said gently. First, we'll perform a lumbar puncture to measure your CSF pressure and remove some fluid to relieve the immediate pressure. Then we'll start medications and discuss long-term management. The lumbar puncture was uncomfortable, but not as painful as Emma feared. She lay on her side, knees pulled to chest, as Dr. Patterson inserted a needle between her lumbar vertebrae. Opening pressure is 42 centimeters of water, he announced, watching the manometer. Definitely elevated. Normal is under 25. As he slowly drained 30 milliliters of clear, colorless CSF, Emma felt that headache begin to ease, like a vice slowly loosening around her skull. "Oh my God," she breathed, "it's getting better." "That's the pressure reducing," Dr. Patterson explained. "But this is temporary relief. We need a comprehensive treatment plan." Over the next week, Emma learned everything about her condition. IIH predominantly affects women of childbearing age, especially those who are overweight, though Emma's BMI was only slightly elevated at 27. The exact mechanism remains unclear, but researchers believe it involves impaired CSF drainage through the arachnoid granulations, specialized structures that reabsorb fluid into the venous system. Risk factors include recent weight gain, certain medications like tetracycline antibiotics and vitamin A derivatives, hormonal changes, and conditions affecting venous drainage like polycystic ovary syndrome. Dr. Patterson started Emma on acetazolamide, a medication that reduces CSF production by inhibiting carbonic anhydrase in the choroid plexus. The dose was 500 milligrams twice daily, gradually increased to 1,000 milligrams twice daily. The side effects aren't pleasant, Dr. Patterson warned. Tingling in your fingers and toes, metallic taste, increased urination, and fatigue. But it's essential to preserve your vision. He also prescribed a weight loss plan. Even a 5 to 10% reduction in body weight significantly improves IIH. We don't fully understand why, but it's one of the most effective treatments. Emma met with a neuro-ophthalmologist every 2 weeks for visual field testing and optical coherence tomography to monitor her optic nerve swelling. The tests showed mild damage already present. "You have some early visual field defects in your peripheral vision," the ophthalmologist explained, showing her the computerized results with areas of decreased sensitivity. "The good news is we caught it before central vision was affected, but we need to be aggressive with treatment." The next 3 months were the hardest of Emma's life. The acetazolamide made carbonated drinks taste horrible, turned her favorite foods metallic, and caused constant tingling that made typing uncomfortable. She felt exhausted despite sleeping 9 hours a night. The weight loss was challenging. Emma worked with a nutritionist, counting calories, measuring portions, walking an hour daily, even when fatigue made every step feel like wading through mud. Her vision improved but remained unstable. Some days were clear. Other days, the world looked like a watercolor painting, edges soft and blurred. She had to reduce her hours at work, stepping back from the creative director track she'd worked so hard for. The medications and fatigue made concentration difficult. Her employer was understanding, but Emma felt like she was watching her dreams slip away. "Maybe this is what my life is now," she told Marcus one night, tears streaming. "Chronic illness, medications forever, never knowing if I'll wake up blind." "No," Marcus said firmly, "we're going to beat this. You're going to beat this." But at her 3-month follow-up, Dr. Patterson delivered concerning news. Despite maximum medical therapy and 15 pounds of weight loss, your visual fields are continuing to deteriorate. The optic nerve swelling has improved slightly, but not enough. He paused. "We need to discuss surgical options." Emma's stomach dropped. Surgery? There are 2 main procedures. A ventriculoperitoneal shunt, where we place a tube to drain excess CSF from your brain to your abdomen, or optic nerve sheath fenestration, where we create small windows in the covering of your optic nerves to relieve pressure directly on them. What are the risks? Shunts can malfunction, require revisions, cause infections. Fenestration is more targeted, but only protects the optic nerves, not treating the underlying pressure. Both have risks of making vision worse. Emma felt trapped. Continue losing her vision slowly or risk surgery that might accelerate it? After consultations with 2 neurosurgeons and extensive research, Emma chose the ventriculoperitoneal shunt. The surgery took 3 hours. A neurosurgeon placed a thin catheter in her lateral ventricle, threading it under her skin down to her peritoneal cavity with a programmable valve behind her ear to regulate CSF drainage. The recovery was difficult. Emma had severe headaches initially, then experienced the opposite problem, overdrainage, causing low-pressure headaches when upright. The valve was adjusted twice before finding the right setting. But slowly, remarkably, she improved. The crushing headaches resolved, her vision stabilized, then gradually cleared. The visual field defects stopped progressing. While she'd lost some peripheral vision permanently, her central vision remained sharp. 6 months post-surgery, Emma returned to work full-time. She'd lost 35 pounds total, maintained her acetazolamide at a lower dose, and saw her doctors every 3 months. "The shunt saved my vision," she told a support group for IIH patients she now co-led, "but I should have acted sooner. I ignored warning signs for months." She pulled up a slide showing her early symptoms: morning headaches that worsen when lying down, visual disturbances, even brief ones, double vision, pulsatile tinnitus, a whooshing sound in your ears with each heartbeat. These aren't normal headaches. IIH affects 1 to 2 per 100,000 people overall, but 12 to 20 per 100,000 young women who are overweight. Many don't know they have it until they've lost significant vision. By then, the damage may be irreversible. A young woman in the group raised her hand. "How do you cope with the fear it'll come back?" Emma smiled. "I monitor myself religiously. Weight management, medication compliance, regular eye exams. I know the warning signs now, and I trust that if pressure builds again, we'll catch it early." She looked around the room. "This condition tried to steal my vision and my future, but it taught me something crucial. Your body gives warnings. Persistent symptoms aren't normal. They deserve investigation, not ibuprofen and hope. Don't wait until you're losing your vision to take headaches seriously. Don't assume it's just stress or eye strain. Trust your instincts. Advocate for yourself. The headache that won't quit might not be a headache at all. It might be your brain, literally under pressure, crying out for help." 2 years later, Emma is thriving. She's back to creative director, her shunt functioning perfectly, her vision stable. She maintains her weight, exercises regularly, and has become an advocate for IIH awareness. She keeps a photo on her desk, her visual field test from diagnosis day, showing those areas of darkness creeping in, a reminder of how close she came to losing her sight. "Every headache isn't IIH," she tells people, "but IIH starts with headaches everyone ignores. Know the difference. It might save your vision. It saved mine." Idiopathic intracranial hypertension is rare but devastating when missed. If you experience persistent headaches, especially morning headaches that worsen when lying down, visual disturbances, double vision, or pulsatile tinnitus, see a doctor immediately. Request an ophthalmoscopy exam to check for papilledema. Early detection prevents permanent vision loss. Don't let just a headache steal your sight.